So we're going to start in a little bit. Thank you for everyone who is coming in. We're going to give our attendees and our panelists some time to join the call. So thanks for coming. Okay, so if you just came in, we are going to start in a little bit. I'm going to give everyone maybe about 3 more minutes, maybe around 12:05 we'll get started. We'll do some introductions and we'll jump right into our event. So my name is Zakiah Stewart. I am a graduate student at Montclair State University, and I am working with the Perinatal Health Equity Initiative as Program Development Specialist. So I will be your moderator today, and we will get started again in just a little. So thank you for your patience, and thank you for joining us today. Okay, so I see we have a few more attendees that are rolling in, and in the meantime, while we give maybe 1 more minute to get started, if you would like to introduce yourself in the chat, maybe just your name, the organization that you're representing, and your role. Thank you. Okay, so it is 12:05. We will get started. I gave a brief introduction, but if you just joined us, welcome to day 3 of Perinatal Health Equity Initiatives. Sorry. Well, welcome to day 3 of Black Maternal Health Week. And today is the Black Policy Corner, part 2. So we have a few guest speakers today, and we're really excited to have them. And so I already gave my introduction, but I'll introduce myself again. My name is Zakiah Stewart. I am part-time program development specialist with the Perinatal Health Equity Initiative. We are going to be touching on a few topics today. Our first speaker is Vuan Foster. She'll be talking about stillbirth prevention and count the kicks. We also have Michelle Samuels and Shen Yi Lin and Rhiannon. They'll be talking about the New Jersey Medicaid expansion in the birth space. We'll have some time for questions in between each speaker. We'll have about a 15-minute break after the discussion on Medicaid expansion. And then we will be talking about New Jersey birth policy with Ellen and Jill Watnick. So we can go ahead and get started. I'm going to introduce Vuan, who again will be discussing stillbirth prevention and count the kicks. So just a little background on Vuan. Vuan Foster studied at William Patterson University, where she received her Bachelor of Science in Public Health. She's currently at Montclair State University and completed her Master's of Public Health, concentrating in health systems, administration, and policy. Me and Vuan are actually classmates, so I'm honored to introduce her. And so before celebrating the birth of her healthy baby boy in July of 2021, she experienced 2 painful pregnancy losses. So she'll be discussing some of that today, some of her lived experiences. She also serves as the Count the Kicks ambassador for New Jersey, and she serves on multiple committees surrounding perinatal health and infant mortality, including the New Jersey Maternal Care Quality Collaborative with the New Jersey Department of Health, where she is the vice chairperson. So as a preeclampsia survivor and a woman who has experienced losses, she's committed and dedicated to making a difference in improving maternal and child health outcomes. So I'm going to pass it on to her and meet myself. Welcome, Luann. Luann, I think you're muted.
Yes, I'm so sorry. Thank you so much for introducing me. It's a pleasure to be here with you all.
So you can get started whenever you're ready. You can share your screen.
Okay, can everyone see my screen?
I think you're good.
Thank you so much. So today I'm going to be presenting on Count the Kicks. I will be turning off my camera during this presentation. So just wanted to let you know that. So we have a highly effective evidence-based stillbirth prevention campaign. This was developed early warning system for moms, and we're saving 1 in 3 at-risk babies. And this is taking place in Idaho. Our campaign is ready to go and it's low cost. And we want to save babies in New Jersey as well. So again, my name is Vuan Foster, and I am one of the New Jersey Count the Kicks ambassadors. And I'll be here talking to you today about the stillbirth prevention campaign, Count the Kicks. So one of the most powerful and effective ways we found to educate expectant parents is our use of moms to mom sharing. Through the testimony of those whose children have been saved through counting and tracking their fetal movements in the 3rd trimester, we've seen a ripple effect helping expectant parents know about a life-saving tool called Count the Kicks. The Baby Save story was shared on Good Morning America, and it's about baby Ruby. Let's listen to her mom, Eileen, save Ruby's life by using the Count the Kicks app.
Parenting alert about a free app. A mother says help save her baby's life by tracking how often she kicked. ABC's Diane Macedo is here with that story. What is this all about?
So this mother says that everything was completely normal in her pregnancy until one day, thanks to this app, she noticed that something was off.
Sorry.
Now to that GMA parenting alert about a free app. A mother says help save her baby's life by tracking how often she kicked. ABC's Diane Macedo is here with that story. What is this all about?
So this mother says that everything was completely normal in her pregnancy until one day, thanks to this app, she noticed that something was off. Well, it turns out her baby was in real trouble.
For Emily and Jeremy Ecoff and 2-year-old Liam,
Oh, nice.
life with their new baby Ruby is extra precious.
We have a healthy baby girl and we could have had a burial instead.
Ruby is lucky to be alive, and her mom says that's largely thanks to an app. The free app called Count the Kicks aims to prevent stillborn deaths by helping moms record their baby's movements.
You can just tap the baby's footprint every time you feel a movement. A movement could be a kick, a roll, or a jab.
Used at the same time every day, the app tracks how long it takes to reach 10 kicks, helping mom learn what's normal for her baby.
And we also send calendar reminders and text reminders so that moms are reminded to do it once a day in the third trimester.
It's just one of a growing number of apps helping parents through pregnancy and labor. For the Ecoffs, everything was going smoothly until one day last month.
The kicks were not happening as frequently as they usually did. And when she did move, it was really like soft, subtle, not like hard kicks like normal.
Emily knew from the app that her baby normally kicked 10 times in under 10 minutes. So when she only logged 3 kicks in an hour, she rushed to the hospital.
All of a sudden, they came in and said, you're going to have an emergency C-section.
The umbilical cord had wrapped around the baby 3 times, limiting her movement. Doctors delivered Ruby just in the nick of time.
Not only has Ruby been saved, but potential generations have been saved.
She sleeps about 23 hours a day.
4 weeks later, Ruby is now home, healthy, and sleeping like a baby.
Doesn't get much cuter than that. Now, the app was made in Iowa, which is where that family is from, but the creators say it's now spreading nationwide, thanks in part to Ruby. Since the news of her birth, the app has gained more than 5,000 new subscribers. So, Robin, the app saved Ruby, and by raising awareness, she may end up saving many more.
So we are still hearing the testimonies from the ripple effect of baby Ruby's story to this day. Stories like this are reminders of why we do what we do.
We're going to turn now to that GMA parent.
Sorry. Okay, so before we go on, I mean, everybody probably knows a lot of these definitions, but I wanted to make sure we were clear before I went on. So miscarriage is the loss of a baby before 20 weeks of pregnancy. Stillbirth is the loss of a baby after 20 weeks of pregnancy. On average, we lose 23,500 to about 24K of babies to stillbirth annually in the USA. As Zakia also shared, I've had a miscarriage as well as a stillbirth. Stillbirth is, oh, I said that. Infant mortality is the death of an infant before his or her first birthday. Now, on average, we lose 22,000 infants every year before their first birthday. So, causes of stillbirth. So we have pregnancy and labor complications. We have problems with the placenta. We have birth defects, infection, and problem with the umbilical cord, and medical complications in the mother. So I just want to read some very important data for you. So 1 in 169 pregnancies end in stillbirth. And the racial disparity is Black moms, 1 in 96 pregnancies end in stillbirths. For Hispanics moms, it's 1 in 199 pregnancies that end in stillbirths, while we have, white moms, which is 1 in 204 pregnancies. So families are 10 times more likely to lose a baby to stillbirth than SIDS. And in the US, we lose 65 babies, which is a busload of children per day. And in the pandemic, we've noticed that the increase of the urgency of stillbirth and mortality rates are on the rise. I also want to apologize because I am a stay-at-home mom, and I will be doing this presentation as well as taking care of my son, who's currently a little upset. So my apologies, but I'll keep going. So why are there so much large disparities for stillbirths in the United States? And research has shown that there are a lot of contributing factors to racial health disparities in the United States, which includes structural racism, barriers to healthcare, which are 2 of the things that I experienced in my pregnancies. We have socioeconomic barriers, toxic stress. Research shows that years of being treated unequally and/or unfair, essentially being an African-American woman in a system of society, and that all that it comes with, conditions that disproportionately affect women, and genetic factors. Okay, so here's some other important information to look at. So one, the stillbirth rate in comparison. So we also want to look at, in New Jersey, 223 babies on average could be saved every year with our campaign. And one of the things that I'm doing as a New Jersey ambassador is we're trying to get this Count the Kicks campaign implemented in New Jersey. And what that would mean is that the materials that are on the website would be able to be given to providers at no cost at all if our state adapts this program. So New Jersey on average loses 696 babies a year to stillbirth, which is a lot. And again, 1 in 3 babies could be saved from a preventable stillbirth campaign like Count the Kicks. So this is some statistics from Iowa, which is where the Count the Kicks campaign started. So the 2020 Iowa stillbirth rate is 4.0 fetal deaths per 1,000 live births. It is the second lowest Iowa stillbirth rate on record after 2018 and one of the lowest in the United States. So I share this because New Jersey can learn a lot from what Iowa is doing, which is implementing this Count the Kicks campaign. So research and evidence-based. Count the Kicks, again, is research and evidence-based. So tracking fetal movement is a non-invasive way for expectant parents to monitor their baby's health in the 3rd trimester. Babies can be saved when expectant parents are educated on getting to know their baby's normal movement patterns starting at 28 weeks, and to speak up if they notice a change. One of the amazing and important things about the app is that it creates a graph to where you can see your kick counting sessions, and you can show your provider if you expect something is not correct. So best practice, Associates of Maternal Child Health Program. After a thorough scientific review, the leading maternal health association in the United States determined that our program is meaningfully engaging stakeholders at all levels of practice, ensuring improvement, health quality components for this program is sustainable, has been extremely validated by other entities and replicated with similar results in other contexts. So here are some other signs of things that you would notice that you would want to let a provider know. So if you have changes in your vision, if you're dizziness or fainting, headaches that just won't go away, a fever of 100.4 or higher, extreme swelling in your hands or face, thoughts of harming yourself or the baby, trouble breathing, chest pain, severe nausea and throwing up, severe belly pain, baby movement stops or slows down. And one of the things I did want to share is that shortly after, as Zakia read, I did have a healthy baby recently after my 2 pregnancy losses. And after I had my son, I had severe headache that wouldn't go away. I had very dizziness. I also had some changes in my vision and extreme swelling in my limbs. So I kept going to my provider, letting them know that something wasn't right. And I was finally diagnosed with severe postpartum preeclampsia. So again, these are some amazing signs to basically be aware of if you have them and what to do. And basically the importance of just paying attention. So kick counting does not increase anxiety in most pregnant women. So I say that because sometimes people are less apprehensive to get the information that I'm providing because they don't want to talk about stillbirth or things like that. But again, it doesn't provide increased anxiety. What it does, if anything, is just makes you aware so that you can prevent a stillbirth. And again, 84% of the app users stated that regular tracking was associated with feeling of bonding, and 77% of app users reported feeling less anxious. I know for me, as a mom who already experienced 2 preventable pregnancy losses, when I used the Count the Kicks app, I was very appreciative that I would be able to have something that would prevent another possible loss. So maternal fetal movement monitoring has additional benefits. What it does is it reduces premature birth rate, fetal growth restrictions identified earlier, and women who have stillbirth are substantially higher for severe maternal mortality than women who have live births, regardless of their fetal death. So proof of impact. Count the Kicks launched in Nebraska in 2016 in partnership with the Nebraska Perinatal Quality Improvement Collaborative. In that time, Nebraska's stillbirth rate was 5.68 fetal deaths per 1,000 live births to 4.15 fetal deaths per 1,000 live births in 2018, the most recent year on record. Nebraska now has the 5th lowest stillbirth rate in the country, according to the CDC. So Count the Kicks launched in Illinois in 2016 as well, and the state has seen a decrease in stillbirths every year since 100 fewer babies were lost to stillbirth in 2018 compared to the year before the launching. So I am hoping that with the work of myself and the other 2 ambassadors in New Jersey, that we will soon be able to get Count the Kicks implemented in New Jersey so that we can see a decrease in stillbirth rates as well. So the impact of COVID. The Washington Post stillbirths have doubled during COVID in Mississippi. Officials are sounding the alarm. Mississippi has recorded 72 fetal deaths and unvaccinated pregnant women infected with the coronavirus. The state health office announced sounding the alarm on virus dangers in pregnancy. So again, Count the Kicks in our free app act as a warning sign for expectant parents. We also incorporate vaccine messaging onto our platform, and we're hosting a webinar with the CDC in October on the topic of vaccines and pregnancies. So again, implementation of Count the Kicks and what that looks like. When New Jersey does implement Count the Kicks, because I have a strong belief that we will eventually be on the road to doing so, the materials which we have online would be free to all of the providers. We will also give a number of trainings to providers, as well as anyone in the community who's dealing with expectant families, so they can be able to better educate their families on kit counting. So kit counting is what moms should do, and it's important and easy tool. So let's start. You start in the 3rd trimester. However, if you are high risk, you start at 26 weeks instead of 28 weeks. So tracking your baby's movements are free with the Count the Kicks app, or you can print out the charts on our website online if you do not have a smartphone. You count your baby's movements every day, preferably at the same time. You count the time that it takes to get to 10 movements, so they don't necessarily have to be kicks, as Emily said in the video that I showed above. It could be jabs, just any movements, 10 movements. After a few days, you will see a pattern for what your baby's average amount of time is. You continue tracking every day, and you call your provider right away if you notice that there's a change or it takes longer to get to the 10 movements than it normally does. So we do have free resources, and you can go to www.counttthekicks.org and download the kick counting charts, childbirth education lesson plans, stillbirth prevention research, the Count the Kicks facts in 10 different languages, and 80+ saved baby stories. We have educational videos and testimonies and instructions on how to kick count with your patients. So again, our app comes in many different languages. It's available on Apple and Android products. You can restart your session and delete a kick if you accidentally tap the button more than once. Review your kick counting history, which I talked about before, where there's a graph that basically shows you on average how long it takes your baby to get to 10 movements. You can download your history to share that with your providers, friends, or families. You can count the kicks with twins if you have multiple babies during your pregnancy, and you can track future pregnancies on the same profile while managing device registered to your account. It is also available on the Apple Watch. So strength tracking and notes features. So this is a new feature that the app now has, and you can basically now track the strength of your baby's movements or kicks. So again, if you notice a change with that, you can reach out to your provider and let them know. Okay, the Count the Kicks app now has video capability to educate users, which is amazing, again, to be able to get information readily at hand. So again, this is our website, and we have basically, we don't quite have this yet in New Jersey, but this is something that would possibly, be if New Jersey was to adapt the Count the Kicks app, where you would be able to put our zip code in and find other resources and related to perinatal health. So lastly, I just want to thank you all for taking the time to listen. And if there's any questions, feel free. Oh, sorry.
The Count the Kicks app, a cutting-edge, powerful tool for expectant parents in the third trimester of pregnancy, has a new feature to help you monitor your baby's movements. The new strength feature allows you to rank the strength of your baby's movements on a scale of 1 to 5, from fluttery to fierce. Research shows paying attention to the strength of your baby's movements is vital. If a baby's movements becomes weaker, studies show this could be a sign of potential problems, and expectant parents should alert their doctor. The free Count the Kicks app now gives you the option to take notes on your session. Our app is available in 12 languages in the Apple and Google Play app stores. It is a simple and non-invasive way to monitor your baby's well-being every day in the third trimester. Features include kick counting history, daily reminders to count, and the ability to count for single babies and twins. Simply tap the footprint every time you feel a kick, roll, or a jab. And the app will time how long it takes your baby to get to 10 movements. Log in to save your kick counting data and get to know what's normal for your baby. Be sure to speak up and tell your doctor if you notice a change in the strength of your baby's movements or how long it takes your baby to get to 10 movements. Hospitals are open 24/7 and are ready to listen to your concerns. Join the community of expectant parents who are in tune with their body and their baby by counting kicks daily in the third trimester. You can also find it on Apple Watch. Download Count the Kicks and start counting today.
So I just want to thank everybody, and sorry, I tried to jump the video. Just want to thank everybody, and if you have any questions, feel free to ask away. And if I cannot answer them now, I will definitely get back to you guys and we can share those answers at a later date and time.
Thank you so much, Luna. That was a great presentation. Hi, King. So yes, if we have any questions for Vuan, this is the perfect time to put them in the chat. And, like she said, if anything comes to mind, we can definitely follow up with you. So Vuan, I just want to thank you for being transparent and sharing your story. I think your presentation was extremely informative. I do have one question, and that is, what would be your number one piece of advice to a new mom? You shared a lot of great information and you shared a lot of great resources, but with all of the experiences that you've had, what would be your number one piece of advice?
So my number one piece of advice would be to trust yourself and trust your body, because I feel like nobody knows you or your body like yourself. So again, for me, in the moments where in my losses where I really wish I would have trusted myself more and continued to push harder and advocated for myself, like, no, something is not right, I possibly could have prevented my losses. But what I will say is, in my last pregnancy, which was with King, I trusted myself because I knew something wasn't right with my body. And I continued to go in, even though I wasn't being listened to, and saying, listen, no, something is not right. And what I potentially did was I saved my life, because I ended up having severe postpartum preeclampsia and I had 33 pounds of fluid that was backing up into my heart and impacting my lung function. And had I would have just listened to the provider saying, oh, this is normal, this happens after pregnancy, which I shared the warning signs with you. Those things are not normal after pregnancy. But again, had I not would have trusted my body and listened to myself, my son wouldn't have a mom.
Thank you so much for sharing that, Lynn. We did have two questions. The first question is, why hasn't New Jersey adopted the Count the Kicks?
So there's a cost associated with counting the kicks. So it's not that they haven't. I'm not sure if you guys attended or listened to the governor's budget address. So they did allocate $100,000 to a stillbirth campaign, but we need to just move forward with that. So I think New Jersey is in the works of doing so. I hope that answered your question.
And then there was one more question, which is what is involved? Well, you kind of answered it in the last question, but it says what is involved in New Jersey adopting counting the kicks?
Yes. So again, we're in the process of completing the paperwork and going after the funding that, again, the governor has allotted for the stillbirth prevention campaign. I believe Count the Kicks, this campaign is valued at $60,000. So again, we are in the works on working on getting that implemented in New Jersey.
All right, it looks like we have one last question, which is about whether or not your slides can be shared with participants afterwards.
So I would need to follow up in regards to that, but I don't think that would be an issue. So if I can share those materials after, because again, I'm not the owner of those materials, then I will gladly provide them so that they can be shared with you all.
Perfect.
And again, I will say, if for whatever reason I cannot share the slides, I did list that if you go onto the website, there are a number of materials that are available free of charge to you.
Got it. No, you're fine. Okay, awesome. Thank you so much, Lynn.
Oh, someone did ask a question about funding. Yes, so you can always share the importance of counting the kicks. Everybody's voice matters. So the more people continue to talk about how important Count the Kicks is, really does help get the word out about the campaign and really put this issue on the forefront. So yes, please continue to do so.
Great. Thanks again, Lynn. I think we're gonna move on to our next part, but thanks for coming and I hope you have a great rest of your day.
You as well.
All right, awesome. So that was our first presentation. We are gonna keep the ball rolling and move on to the next part of our presentation if our presenters are ready. We are going to be discussing the New Jersey Medicaid expansion and the birth space with Michelle Samuels, Shin Yi Lin, and Rhiannon Reeves. And they're at the Division of Medical Assistance and Health Services. I'm just going to give some background for each of the speakers. So Michelle Samuels is a registered nurse at the Quality Assurance Specialist, or as a Quality Assurance Specialist with the New Jersey Division of Medical Assistance and Health Services. She is a registered nurse and she has specialty nursing experience, including Medicaid benefits and eligibility. She is currently assisting with the implementation of New Jersey's Medicaid doula services for benefits and other New Jersey Medicaid maternal health initiatives. Michelle brings her clinical background as well as several years of experience with the state of New Jersey, collaborating with providers in various healthcare settings and other state agencies. Okay, so next up we have Shin Yi Lin. She works as at the policy office in New Jersey's state Medicaid agency through the New Jersey Department of Human Services, this is a mouthful, in the Division of Medical Assistance and Health Services. So that's DHS and DMAS on maternal health policy. And so some of her work includes implementing the New Jersey's community doula benefit. In 2021, she had birth doula support for all of her 3 births in New Jersey. So she definitely has experience. And so Shin Yi comes to policy work by way of a career as a geneticist, bringing her perspective as a scientist to support evidence-informed and evidence-based policymaking. And last but not least, we have Rhiannon Reeves. She's a program manager with DMAS. Within DMAS, she's primarily responsible for leading policy analysis and implementation of health equity objectives within the division's program and policy, as well as leading a diversity, equity, and inclusion strategy to support DMAS and its employees. In this role, she is a doula. She is also a doula guide, helping to assist interested doulas in enrolling in New Jersey's family care as a fee-for-service provider. She also has a background in advancing equitable outcomes through public policy, having worked for a policy for policy think tanks in Washington, D.C. Additionally, she was previously employed by Women of Color Reproductive Justice Collective in Atlanta, Georgia, whose purpose is to build an effective network of individuals and organizations to improve institutional policies and systems that impact the reproductive lives of marginalized communities. So without further ado, I'm gonna pass it on to our next speakers.
Hi, and good afternoon, everyone, and thank you for having us today. Before we begin, I wanted to again start by thanking the Perinatal Health Equity Foundation for inviting New Jersey Medicaid to participate in today's event, allowing us to highlight some of the work that we've been doing. We also want to apologize in advance due to some health issues among our staff. We've had to scale back our presentation for today, but we are still excited to focus our conversation on how we've put policy into action by specifically focusing on the work of the community doula benefit, which has been going on for a couple of years now, and we feel is the kind of work that and a kind of policy that directly addresses the Black maternal health crisis, specifically in the state of New Jersey. So like many of you in attendance today, New Jersey is painfully aware of the state's poor statistics regarding maternal health and infant mortality, including subsequent maternity-related racial health disparities impacting Black birthing people and their babies. Specifically, New Jersey's maternal health outcomes and disparities are among the worst in the country, with Black women in the state being approximately 7 times more likely to die from pregnancy-related complications than white women in the state. In an effort to combat this crisis, First Lady Tammy Murphy implemented the Nurture New Jersey initiative, which is where several of New Jersey Medicaid's maternity reforms are being put into place. Additionally, for the purposes of this conversation, I wanted to also state that we'll be commonly referring to our Medicaid program as New Jersey Medicaid. However, New Jersey's Medicaid program is run by the Division of Medical Assistance and Health Services, or DMAS, which sits within the New Jersey Department of Human Services. And the New Jersey Medicaid program is primarily branded as being New Jersey Family Care. But again, we'll be using New Jersey Medicaid for this conversation, but you will see all of those things everywhere, and it all just boils down to being New Jersey Medicaid. New Jersey Medicaid often partners with sister agencies such as the New Jersey Department of Children and Families, as well as the New Jersey Department of Health, among others. And as you can see in this little box here on the right, a broad set of initiatives that are in the Nurture New Jersey initiative are aligned and housed within New Jersey Medicaid, which presents an opportunity for New Jersey Medicaid to engage with the First Lady's office on a fairly regular basis on issues such as doulas, or specifically community doulas in New Jersey. Next slide, please. Is there a slide? Oh, here we go. So I'm so sorry. Okay, so why community doulas? In the beginning, New Jersey Medicaid was aware of the benefits of doula care. As you can see, the March of Dimes statement on the right regarding doula care says it best. And so much like other states, we began implementing a doula benefit within our Medicaid system. Unlike these other states, which are primarily focused on providing labor support, we opted to go with a community doula approach. This decision came about as a result of our work with our doula stakeholder group, in which we gained a better understanding of the community-based doula model specifically, and how it can serve the needs of our Medicaid members in a culturally competent and responsive way. This is due in large part to the fact that the doulas themselves are often reflective of the communities that they serve and have knowledge of community resources available to birthing people and their babies. And a little later on in our presentation, my colleague, Michelle Samuels, will go into a little more depth regarding community doulas. So in implementing an effort as monumental as this, New Jersey recognized that in order to be successful, the work couldn't be done in silos. As a result, the New Jersey Department of Health and New Jersey Medicaid have been working together in this effort. The New Jersey Medicaid program subsequently has oversight of our managed care organizations, which doulas contract with to receive reimbursement for their services. Additionally, our doula stakeholder group began working with a core group of 4 New Jersey-based community doula training programs that were specifically created to address racial health disparities in maternal health experienced most acutely by Black and Brown birthing people. And 3 of those community doula training programs received funding from the Department of Health as a pilot site in their Healthy Women, Healthy Families program. And the graphic on this side kind of aims to provide a visual breakdown of the various players involved in the effort and how it's all housed within the state of New Jersey.
Okay, so as Rhiannon mentioned, we, in order to build the doula benefit, we used a stakeholder approach. And what that means is, you know, beginning in 2019, we had the assistance of some of the women from, or some of the doulas from the New Jersey Healthy Women, Healthy Family pilot. And they joined us in helping to shape what we have as New Jersey's community doula benefit. So as you can see here, as I mentioned, some of the partners were Department of Health, we had the doula nonprofits, and then later on in the stakeholder meetings, we added some of our New Jersey family care managed care partners. So as we began these meetings back in 2019, and they continued throughout the development of the benefit. And we are continuing to, as the benefit goes live, as it went live in January 1st of 2021, we're continuing to hold some of those discussions.
And I think one thing, you know, we want to share in talking a little bit about the background behind this benefit is really seeing not only that, you know, that there was a stakeholder group convened while Medicaid was in the early stages of developing the benefits, so that we were incorporating stakeholder feedback in how we design the benefit, but also to see that we realize that in order for this benefit to be a success for those birthing individuals who are on New Jersey Family Care, that it's really important that we begin to build trusted relationships across our community doula workforce and the state partners from the very beginning. So as Michelle was saying, Michelle and I remember the early meetings that we had in 2019, which started before COVID, and we were all meeting in a conference room. And it was an opportunity for doulas to directly get to know not only the staff at the different, at the Department of Health and also at the Department of Human Services, and kind of put faces to names. Our assistant commissioner was able to, you know, connect with the doulas, you know, mom to mom, parent to parent, and I think that, you know, that's an essential part that we've continued to work on, and that's the reason why we continued to meet. It wasn't just let's meet at the beginning and then stop. No, once COVID hit, we transitioned into virtual meetings. You know, the initial meetings were very focused on the benefit itself, but we obviously had to pivot given COVID, and it was an opportunity for the doulas, many of whom were still serving clients throughout the pandemic, to give us direct feedback on, you know, the challenges that we know birthing individuals were facing in being pregnant or delivering, or that postpartum period, especially in the early days of the pandemic when, lockdown was, and the transition to telehealth and everyone was sort of pivoting. And then as we got closer into January 1st, 2021, when our Medicaid benefit went live, it was an opportunity to make sure that we were listening to doulas as to, what was the best way to actually, now that the benefit was designed, how do we actually roll it out successfully? And these stakeholder discussions have continued to happen through last year and will continue this year. And we've added more people into the stakeholder discussions, like as our community doulas are joining our provider network so that they can serve our members. They've been invited to join the stakeholder group. And then we'll touch upon the Doula Learning Collaborative, an organization that I know presented at another panel session this week about their role in this whole ecosystem of, that wraps around how New Jersey is thinking about the community doula benefit. I don't know if there's anything else you wanted to add, Michelle, before you move on to kind of talking about how that feedback impacted where New Jersey landed with its Medicaid benefit.
I think we're good to go on to the next slide. Okay, great. So here I'm really just going to discuss some of the key features of the benefit, as Shinyi mentioned, and as we discussed earlier, how important that those stakeholder meetings were in shaping or deriving our benefit, where we heard directly from doulas, about some of their experience that helped to pull this benefit together to make it what it is. So, and just to touch on that, if anybody wants to see any more detail about our experience with the stakeholder group, in that little blue box, you'll see there's a link, and those are some slides that we have that have a little bit more in depth than some of these slides that go into exactly topics and case studies, et cetera, that we heard from doulas and how that affected the way that we developed the benefit. So the focus of the Medicaid benefit, obviously, as Rhiannon mentioned earlier, is a community-based doula model. I'm sorry. After lunch, just trying to get it together here. So the community-based doula model. So where the doula workforce is a reflection of the community that the doulas are working and living in that community. So, so with this, they're not only hopefully members of the community, and also they could provide that culturally competent care, and they have some knowledge of specific services that are available to the members in the community, possibly specifically, or also, social services that may be more New Jersey specific. Moving on to the benefit. So the benefit goes beyond just that labor support. It's also available through pregnancy, labor, and the postpartum period. And so our visits are pretty much nondescript, where a member can come into care at any time during the perinatal period. So if a member comes late to care, they can still access services and the full services. So let me describe the benefits that we have available. So there's two types of benefits. We have the standard benefit, which is 8 doula visits, in addition to 1 initial visit, plus the labor support. And the 1 initial visit is separate from the other visits because we heard from the doulas as we were building that initial visit requires, a lot more time to get to know the mom. And it takes a little more time to develop that relationship and, identify any risk factors, et cetera. So that initial visit can be up to, I believe it's about 90 minutes. and the other visits are up to 60 minutes. So our standard is the 8 visits, the 1 initial visit, and the labor. And then we have an enhanced model for those younger members. And we developed that enhanced model, like, as I mentioned, as in, as we talked to our stakeholders and we talked to the doulas and we heard case studies, and we were hearing case studies where our younger members needed some of that extra care, just, maybe some more hands-on care, maybe more, it just took some more time to address any issues that they might have. So those members, the younger members, are eligible for 12 visits, plus the initial visit, plus the labor support. So moving on, the providers. So our community doulas have the choice to practice independently. They also can practice as part of a doula organization. So a doula can come into Medicaid as an individual doula and provide services, submit claims individually, or a doula can be part of that doula only group and come in as a group. And also, on enrollment, our doulas that come into Medicaid, we've tried to eliminate some of those administrative fees around enrollment. So enrollment into Medicaid is at no cost. Also, our fee-for-service requires background checks, and those are also at no cost. And you know what, just backing up, one other thing I wanted to mention, and I think it's here, about the doula visits. The doula can visit a member in her home, in the community, or a clinical visit. And I just wanted to emphasize the clinical visit, because I think that, we heard from our doulas that it also may be important to attend that visit with a mom to, help to advocate for the mom. So just kind of wanted to back up and mention that. So moving on, as we mentioned earlier in the timeline, we implemented the coverage of doula services within Medicaid in January of 2021. And so after implementation began, or after we began covering those services, we began kind of focusing our efforts on support of the doulas and supporting them to, become Medicaid providers and become providers in managed care. So I'll pass it off to Shani for the next slide.
Thanks, Michelle. And I think before I talk a little bit about the workforce support, I do want to kind of pause here on this slide to say, sorry, isn't this COVID times, we all invite everyone into our homes. Here are our families. That's my youngest daughter. And I guess related to the talk before, she after I gave birth to her, I also had postpartum preeclampsia. So there's connections to I definitely hear connections to what other people today have talked about. But so apologies. And thank you for your forbearance with my family at home. But we did want to just sort of highlight here on these key features of the New Jersey benefit that a lot of this was unique in the Medicaid space when we announced our benefit. When you looked at the other existing Medicaid doula benefits in the state, in the country, a lot of them did not focus on trainings that were designed in New Jersey, that were built by New Jersey sites so that they were tailored to the specific community. The other Medicaid benefits did not have as many visits allowable. But again, we heard from our stakeholders that sometimes it wasn't as easy as 3 or 4 visits and done, that they needed to have many more visits in order to properly support the client. After we released after we launched our benefit, other states were particularly interested in this $100 incentive that's built into our benefit to connect, that if the doula sees the client one-on-one, and then also has the client also goes to the obstetrical postpartum visit, then the doula gets an additional $100 incentive. Other states have been particularly interested in that model because it incentivizes coordination of care, which, is one of those things that that doulas can be very beneficial in creating those bridges and those advocacy avenues for their own care between all their providers. So maybe not just the obstetrical provider of prenatal care, but obviously the obstetrical provider and the nurses in the delivery room, but also potentially in the postpartum period with their pediatrician. So we wanted to include all of that. And that also is why we explicitly allowed, back to what Michelle was saying, wanted our benefit in New Jersey to allow the doula to get reimbursed if they were accompanying clients to any of those clinical visits. So I just wanted to highlight those because, to give you that sort of broader policy framework of what New Jersey was doing that was different than the existing benefits that were out there. And again, I just want to emphasize just how grateful, and we've said this directly to our community doulas, how grateful we have been for their partnership from the very beginning. We're 2 years in and we know the work is going to continue. So with that, let me get to what Michelle was talking about, which is that we knew that if our community doula benefit was going to, or is going to be successful to make the impacts that we hope it has the opportunity to make in New Jersey, that it's not enough to build the benefit that we showed on the prior page, which is sort of just nuts and bolts of, making sure doulas can enroll and, how many visits can they get reimbursed for and things like that. But that because doulas are generally brand new to healthcare systems. So in general, doula care is not a normally reimbursed benefit in the commercial space even. Usually families are paying out of pocket for that kind of support right now outside of Medicaid. And so we knew that if we were going to invite doulas into our Medicaid program and also ask them to support our members, we needed to give broader support to doula providers compared to maybe what we would normally need to provide, say, for a obstetrician or a pediatrician who's looking to enroll in Medicaid, because they're, in those cases, they may already be part of a practice, or they might be part of a hospital system. They might have an office manager who does, all their enrollment and billing support, or maybe part of their training, their clinical training, at least gave them some sort of taste of the bureaucracy and the paperwork involved with healthcare system. Doulas are coming to this without that. They come to this work very, often with personal stories. They're committed, passionate to this work, and are stumbling into it maybe by hearing from other people and things like that. And so from the very beginning, we were really focused on providing lots of from the very first step documentation of like, these are the steps that are needed to become a Medicaid provider. And we tried to improve transparency on our own system from the very beginning. So, and I think this has been a learning experience, not just for our community doulas, but for Medicaid itself, because again, as I said, we're usually dealing with clinical providers that have that whole infrastructure. And so we've learned a lot about ways to make more transparent our process and streamline processes and provide support as necessary. So one of the things we really heard from our doulas was, please have a one-stop shop of information. And so back in early 2021, we launched a doula benefit website. And on there, we put trainings, we put paperwork that was needed. We put links to how to, how to enroll, who are our managed care, what is managed care, and a lot of those kinds of things. We're continuing to add to the website, so it's definitely not a static source of support. We're just continuing to build on it as we hear back from the doulas, and that has definitely, if you looked at the website a year ago compared to what it looks like now, it has a lot more documentation, and it's all been based on the back and forth with our community doulas. I think the other thing we heard was needing to blend multiple levels of support, and that support needed to be one-on-one. So we didn't want doulas to just be interacting with Medicaid as a whole or our managed care as a whole. We wanted there to be a personal relationship. And so very early on, we established the role that Rhiannon was talking about, the doula guides. These are members of our Medicaid staff that are sort of the first point of contact for community doulas wanting to engage with Medicaid. They say, hey, I'm a doula, how do I help serve Medicaid members? So we have a specific email address, which will pop in the chat in just a second, where doulas can email and get that support from the very beginning. And then, because most of our members are with our managed care organizations, and a couple slides ago, Rhiannon showed you a slide that we have 5 managed care organizations that serve Medicaid members and are part of our Medicaid program. And so as our doulas are interacting with each of those 5, we made sure that there were points of contact, identified staff that they were interacting with who had been at those early stakeholder meetings, so that, that's meant to ideally that when the doula is interacting with the MCO, they're talking to someone who knows what a doula is, who knows that the benefits, the early conversations from 2019, 2020, and can be also that sort of personal face to the process. And then, and even on top of that support, there still needs to be a peer-based support. Community doulas really, we heard, learn from each other. It's very much a peer support model that is embedded in their training and also in their practice, that they continue to reach out to each other in community. And so as much enrollment or claim support we could provide from us directly through our doula guides or indirectly through our managed care, it wasn't enough. We also needed to make sure that there was this peer-to-peer support for the whole process. And that's where the Doula Learning Collaborative has come in, and I'll talk a little bit more about it in the next slide. And I think this last point actually transitions really well to the next slide, which is that in addition to the support focused on enrollment and billing, that doulas aren't operating in a silo. Again, it's just like we were saying, it wasn't enough to just nail down what was the benefit going to be shaped like. It's not enough to make our systems more transparent. We also have to be sort of part of the conversation in supporting doulas more broadly. And, something that we have heard continuously, and in particular, our partners at the Department of Health have heard about, is the need for regulatory support. This came up particularly during the early days of the pandemic, and continues to be an issue, where birthing individuals were wanting the doula to be with them to provide labor support, but the doula was counting, counting, I don't want to say against them, but counting as part of their, the invited guests that they could have to support them for labor. And so that would mean, that some of the birthing individuals were choosing between, do I have my partner or my mom or my family member, or do I have my doula? And so the Department of Health did release an executive directive that doulas are part of the essential are essential to the care team during labor and delivery. And this is, again, a way to show you that we are thinking really broadly about what workforce support means for the doula community at large, and what Medicaid's role is, that we are part of a broader whole. And I think this relates to a lot of, sort of our ongoing work and our next steps work, which is really about, we're mostly moving through what's called the technical challenge. The technical challenge was sort of the early design, the policy decisions. How do we make sure claims get paid, and how do we make sure applications are out there, things like that. But we're now moving into adaptive change, which is that we know that it's not just about getting doulas enrolled and getting doulas paid, although that is absolutely important. It's also about educating our members and our clinical partners and our hospitals, like, what are doulas? Because I think a lot of people who have been in the maternal health policy space may know about doulas, but that doesn't necessarily mean, Rhiannon on the street, Michelle on the street is aware of what that is, and what a doula can provide. So we need to do more public awareness. We need to find clinical champions who say, hey, I've worked with the doula, it was great, and this is what we could do, or, hold up any of those positive stories of where doulas have been able to really support a member, and have that impact that I think, all doulas who go into this work are hoping to have in the birth experience and the whole broader perinatal experience of birthing individuals in the state. And I think, really thinking holistically about, and I think hopefully our earlier slide, which we can go back to about all of our Medicaid initiatives, is we didn't just focus on a doula benefit and then nothing else. No, we know that the doula benefit is one piece of the puzzle, and that all those other kinds of supports that and all the other kinds of benefits that we might be able to expand out are ones that we want to think about and build, because we don't want to put it all on doulas themselves. We need to also, make sure we're expanding access to coverage. We want to we want doulas to be just one of many types of peer-based supports our members can have access to within Medicaid. And so that's sort of, thinking about the broader universe of our benefits, and doulas are one key piece, but not the only piece, and wrapping that all around holistically. And then, of course, continuing to just support our community doula workforce. And I think there's many levels to that. That's ensuring we're working with our Department of Health colleagues to expand access to training, because we know that sometimes training can be very expensive. And so Department of Health has been really focused on looking to stand up for people who are interested in entering into doula work. How can we do that with the most minimal level of financial burden, especially since many doulas our doulas are coming from the community. And then working with the Doula Learning Collaborative, which is this new statewide professional organization that's going to help with training, that's going to help with billing and enrollment support, and also is going to really importantly help with reflective supervision, which is really professional support. We know that there's lots of churn within the doula workforce. Oftentimes people do it for a couple years and they either burn out or they transition to other things, particularly for community-based doulas who are working with members who may have had more trauma and are having to help the client navigate through either implicit bias or explicit racism during their perinatal journey. Like, that wears not only on the birthing individual, but also on the doula themselves. And so reflective supervision is, we're hoping, an important tool and toolbox to sort of sustain our workforce so that they can continue to do this work for as long as they want to do it. And so with that, let me turn this back to Michelle. I know Rhiannon talked a little bit about wanting to leave you with a couple resources. So I'm going to switch over to that resource page.
Hi, yeah, so just to talk about resources, we kind of wanted to, as Shani mentioned, leave you with some information, and we'll make sure that these slides get to Dr. Davis to hopefully make them available so that any of these links are available to anyone who who is interested. So we just wanted to go over a few things. So here you'll see in the one box, if you know of anyone that would like to be a trained doula, there is an upcoming training through the Department of Health. It is a New Jersey perinatal community health worker training. I know the applications are due today, but hopefully I believe the application only takes about 20 to 30 minutes. So if anyone is interested, feel free to access that link. Hopefully maybe I can copy it and put it in the chat. So if you know of anyone that's interested in becoming a doula, that is free doula training. Additionally, there are also some other ways to becoming a doula. There are links to the approved trainings document that is on our website. So you could also become a doula that way. If you're not able to get into that deadline of today, there are some other approved trainings. And then for other options, you can also contact the Doula Learning Collaborative. And I know Shani talked about the Doula Learning Collaborative and how they provide some support to doulas, but also to those interested in being a doula. So for anyone who is already a community doula and wants to provide service to our members, you could feel free to email our doula guide mailbox, and our doula guides are always there to help and get those members enrolled and help with that enrollment process and answer any of those questions. So that link is there. And if you know anyone who is on New Jersey Family Care and wants to get or wants to access any community doula services, they would reach out to their New Jersey Family Care Managed Care organization. And they could speak to them and ask them about doula services. As we mentioned, our stakeholders, the managed care organizations, were part of our stakeholder group. So they have specific contact people for a member to be able to find out about accessing a doula. And so now I'm going to kick it off to Rhiannon before we answer any questions. Thank you.
Right. So before we take any questions, we again want to thank the Perinatal Health Equity Foundation for allowing us to speak today. And again, acknowledge that New Jersey's statistics around maternal health and infant health are relatively poor. And this is why we here at New Jersey Medicaid are extremely passionate about joining in on efforts such as these that seek to find solutions to this maternal health crisis. So with that, we would also like to thank all of you in attendance today for participating, and definitely look forward to answering any and all of your questions.
Awesome, great job. Thank you so much for sharing your expertise. That was super informative, and we do have a few questions in the chat. So if you don't mind, I'll share those with you all. So the first question is there a list of doula providers that are licensed or accepted by the New Jersey FamCare? The PRA only has very few and quickly fill up.
So I'm not 100% sure. I think maybe that when they talk about the PRA, which is the perinatal risk assessment, they may be talking about those. So initially when sort of the New Jersey dialogue about community doulas began, it goes back to that where we started with those DOH funded Department of Health. Sorry, I'm trying not to do jargon on this call. Department of Health, which is a separate department, they stood up a couple of pilot sites that one in Central Jersey, one in North, and one in South. And I think some of that intake came through and maybe utilize the perinatal risk assessment. So I think that might be what the questioner was mentioning. And so there were limited spots because that was grant funded dollars. With the Medicaid benefit, it is open statewide and available to all members. So the question was, is there a list? So so one thing I just wanted to make clear is we don't, doulas are not licensed in the state. That's not something that New Jersey, or to my knowledge, any state in the country does. But we do have a list of community doulas that can serve Medicaid members. And just so you know what that difference is, there obviously are many doulas that practice in the state. There are tons of different kinds of trainings that that doulas can bring to bear. To be a Medicaid enrolled doula, we do have more specific training expectations. So either to come from one of those 4 New Jersey specific trainings, or you can come from another set. There's a small set of trainings that you can add on to supplement that training, to have enough training to meet our training requirements. And yes, that list is available online. I will try and put it in the chat.
I dropped it in the chat. All of the providers that are
Rhiannon.
currently accepting Medicaid can be found in our provider directory on our MMIS site. And when you go there, you have to, I can't give you the exact link because there is no exact link. So you just have to go into the provider specialty drop-down box and go to doula providers, and a list of doulas currently accepting NJ Family Care will pull up. It'll let you know where they're located and all those good little bits.
And if you happen to be with one of our 5 managed care organizations, it is also good, after you've taken a look at that, you can also, we'd recommend to call your managed care company, connect with their, specifically, you can say, I would like to talk to your obstetrical case management. Those staff members have been in those stakeholder meetings that we talked about, and they know about the doula benefit. And they can also, if you don't want to wade through like a list, you can say, hey, I want to reach, you know, I'm using this as an example, you know, WellCare's obstetrical case management. I'm a member, Shani, get connected to that staff member and say, I want community doula support. I live in, you know, Hamilton, New Jersey, help get me connected to care. Like, you don't have to do that waiting on your own. We certainly encourage you to take advantage of your managed care organizations and the staff there to help connect you to care. Michelle, is there anything else I should add about that? I want to make sure I'm, and thank you so much, Rhiannon. That was awesome.
Yeah.
So there was a follow-up question, and you may have answered it in the first question, but it was about whether or not supplemental Medicaid, NJSPCP, is a program that's eligible for doula services.
Right.
So go ahead. I was
We're both answering.
Do framing on NJSPCP first. Michelle, is that where you're going to go as well?
You can do the framing. I was just going to go ahead.
Okay, sure. So the overall framing is just so, because that might be jargon that the other people on the call may not be aware of, is that you have to meet different eligibility requirements in order to be eligible for Medicaid coverage. And there are people who birthing individuals who can meet our financial requirement for getting Medicaid, but they are ineligible due to their current immigration status. And so what was set up almost over 20 years ago is this program called NJSPCP, which is designed to be able to provide limited prenatal coverage for those pregnant individuals who would otherwise be eligible for Medicaid, but aren't eligible due to their immigration status. So it's a pool of dollars. And I will say that was on our list of parallel initiatives that we've been working on. In fact, that program has seen a lot of growth, not growth. It's been funded in the last year's, in the governor's budget for the past budget that went from July of last year to June of this year. That program was expanded so that we could provide prenatal coverage to more pregnant women who fall into that category. So that can include, say, like undocumented and others. And there also have been some additional enhancements to that program to help a little bit with intraconception care. But and then Michelle, do you want to answer the specific question?
So just to follow up on what Shinyi said is, yes, we have recently expanded the NJ SPCP program, which is formerly New Jersey Prenatal Supplemental Prenatal Care Program. Now it's the Prenatal Contraceptive Care Program. As of the beginning of this month, they added the contraception that Shinyi mentioned. I just wanted to mention the core question was about doula services. That is a TBD. That's a coming soon. We're working on adding doula services to that. We really don't have a date on that, but that should be coming within the next year.
And I think that's been something we've heard from our community doulas. Some of our community doulas serve birthing individuals who are covered by NJSPCP. So we have been hearing very early on that this is a population that could also benefit from doula support, and that, as Michelle said, it's a work in progress in terms of those conversations. Zakai, do you want to keep throwing questions at us? We're always happy to.
So sorry. Okay, so I see that Rhiannon shared the Nurture New Jersey strategic plan. Someone asked, do you know if any of the doulas in New Jersey are comfortable with unassisted home births? I think Nastasha replied to that, and that we don't suggest or support unassisted home births. There was another link shared.
And can I just pause real quick on that Nurture New Jersey? And this is just for people who maybe aren't aware, that Nurture New Jersey strategic plan goes well beyond Medicaid. That really is our First Lady, Tammy Murphy's sort of vision for making, New Jersey the safest place to give birth and raise a baby. And so just, that's a very high level way for, if any of you guys are interested in sort of what her office's efforts are through all the different state agencies, what kind of efforts are being made. And I think in many ways it parallels the doula work insofar as you start with one thing, but as you know, with maternal health, it's like an onion. You have to keep, it's not enough to deal with one thing in silos. You have to think of the system as a whole. And hopefully for those who are not aware of the Nurture New Jersey efforts, that maybe that strategic plan is a way for you to just learn a little bit more about that sort of expansive view that's ongoing right now. Sorry, I just want to give some framing for that link.
No, that's fine. And so the next question was about the visiting. So the first question is, for the initial visit, is that a part of or is that in addition to the 8 visits that are allowed?
Right, so I wanted to speak to that. So the initial visit is separate from the 8 visits, right? So and I kind of wanted to back up with that because I had mentioned that our visits are non-prescriptive. So, a mom could come late to care. She could come right before she delivers and get that initial visit, have her delivery, and still be eligible for 8 visits with a doula after her, in the postpartum period, after she delivers. So that's what I mean about the non-prescriptive part of our benefit. And the same with the enhanced model. If it's a younger member, they would get those 12 visits. So they can be, those visits can happen at any time during the perinatal period.
And sorry, just to be triple clear, because I think Michelle was emphasizing the sort of non-prescriptive nature and the way in which we're allowing client and doula to kind of engage in shared decision making to see what's the best way to do those visits is when we say 8-1, you'll see in a lot of our materials, it's like 8-1, 12-1. That's referring to either the standard or the enhanced benefit for if the birthing individual is younger than 19 or 19 years or younger. Is the 1 is referring to the labor support. So everyone gets access to at least 1 labor support. And then there's either 8 or 12 total visits that occurred at any point around that labor support. And of those 8 or 12, one of them can be that longer 90-minute visit. So, so that 1 is part of the 8 or the 12. It's just that whereas the other visit, so just to be clear, for example, is that Shani meets up with Michelle and says, Michelle, can you please provide doula support for me? I'm a New Jersey Family Care member. You're a New Jersey Family Care community doula. And so we have an initial visit, in the 2nd trimester. That one can go 90 minutes. And then we can decide, okay, can we do 3 more before I give birth? Because I kind of want to talk out my birth plan, or I'd like you to come with me and meet my obstetrical provider, whatever it is. That can be the additional 3. Then you can have labor support. And then I can say, hey, Michelle, can you come back and see me for 4 times in the postpartum period? And so that's how you can build up that 8-1. That's one example.
And so might have also answered this, but are the visits included after delivery was the next question?
And yeah, absolutely. You can have, if for some reason the member only wants 1 visit postpartum, they can do all 7 visits in the front end, have their labor support, and then have their 8th visit in the postpartum period. But it can also be the opposite. If the member and the doula have a discussion and say, hey, look, we're good. We're going to have an initial visit, 1 in the prenatal period, and I want all of them 7 in the postpartum period. That's also allowed. And then we also, just to be clear, even though labor support is included, if you are a birthing individual on New Jersey Family Care and you're only right now saying, wait, I delivered a month ago, I didn't even know doula care was even covered by my coverage, you can actually start doula coverage now. You can have 8 visits starting now. So you can have postpartum only coverage with a doula if for some reason this is the first time you've heard about it and you think you could benefit from postpartum doula support, that's also allowed. Michelle, is that just want to make sure you didn't have anything else to add.
Awesome. So we do have a few more questions. You all have time for a few more questions in the chat? Okay. So it looks like the next question is, what about the elective induction of labor at 38 to 39 weeks for the Health Start clinics? How are the doulas educated about this and the ARRIVE trial? The pregnant person ends up being harassed about going in on Thursday Eve to have the baby by Friday. I know 2 personally. So the person that asked this question might be able to explain their question better.
I was going to say, I think I understand, and if I'm not answering correctly, you can let me know. So I don't know if we can speak specifically to doula training in this area. But what I can say is that, as I mentioned, a doula can attend a clinical visit with a member. Able to help to advocate for that individual at that time. But additionally, and I don't know if anyone was on the call yesterday, I think it was Representative McKnight, if I'm saying her name correctly. She talked about legislation that has been enacted, which Medicaid implemented back in January, where we prohibit any early elective delivery. So any C-section or induction that occurs prior to 39 weeks that is not medically necessary, we do not pay for that. And we have specific coding related to that. So that legislation was put into place to help to combat those issues.
And that's specific to Medicaid. Just when Michelle is talking, we, New Jersey Family Care, does not pay for early elective deliveries.
Right.
And it was put in place to sort of disincentivize providers from getting paid to do non-clinically appropriate early elective deliveries.
Right. But it should be in practice throughout hospitals in New Jersey. Prior to us implementing that piece of legislation, the New Jersey Hospital Association had a big push to inform providers and give them detailed information surrounding early elective deliveries and the negative effects that they can have on, our moms. So that legislation was put in place.
Thank you. So some more questions. The next question is about the application. It says, is the same paper application online to apply?
So there are many ways to get you're connected to New Jersey Family Care coverage. I'm gonna at least just put in the link to newjerseyfamilycare.org. And that is one way. It's online. You can also walk into county specific offices. I'll try and see if I can find the link to those offices, but you can also go to Get Covered NJ, which is it's New Jersey specific insurance marketplace. And maybe you're not sure, am I right on that cusp of financial eligibility? I don't know. You can also fill out that Get Covered NJ application, and depending on what you fill out, you may end up having your application go through our system. And so I think the question is really talking about
I think the question was speaking to providers specifically,
I'm sorry,
how they apply. And so I wanted
Thank you,
to be clear.
Rhiannon. I'm sorry,
I wanted to be clear.
Member specific. Thank you so much, Rhiannon.
Yes, I'm looking at the chat and I see when the question came in. Were you asking, Nastasia, whether or not the application is the same? The application for the training that is closing today is the same as the application that you would see online if you're just applying to become a Medicaid doula provider in New Jersey?
Yes, so I'm asking about the actually getting a Medicaid number. Is it the same application that's on the website that you fill out the paper one and mail that in, and then you can be credentialed as a doula provider that can accept Medicaid? Because we'd be registering as an organization, not as an individual provider.
So there's two applications, right? There are two applications on the website, and it can be done in paper or electronic form. One is for an individual provider, so for that individual doula to apply for Medicaid. The other is for a group provider, for a doula group to provide services to Medicaid members. Does that clarify?
And again, it's not just paper, it's a PDF fillable form, so you could also do it virtually. We actually really appreciate when people send it in electronically. It helps move the process along a lot faster. And regarding applying as an agency, that's perfectly fine. What will have to happen though is you will have to have at least 2 providers attached to the application that have already gone through this fee-for-service process where they've already received their Medicaid ID. They would have to be also listed on your agency as providers.
And let me just help by being a little concrete. Let me share my screen just real quick, just so you can see what we're talking about. To the first step, and actually, let me first show you. I'm sorry, I'm trying to. I'm seeing both your faces and the website that I'm trying to link to. So the first thing I would say is, we have a lot of, this is the doula website that we were talking about. And so if you're looking to, you are a doula and you want to start the process, maybe starting here would be a good step, and we have a particular document here, steps for doulas to enroll. If you click on it, it's like a one pager, or I think it's one pager with some extra information about what are the steps. But the application that Rhiannon was just talking about, if you go to that NJMMIS, and maybe Rhiannon, you can pop that back in the chat. If you are a doula and you're looking like, I want to serve Medicaid members, you would then click on provider enrollment application. And just so you know, this provider directory was the other link that Rhiannon was talking about. If you want to find doulas, you would go to provider directory, but you would go to enrollment application, and then you can see that when you see doula, there's a group and then there's an individual. So hopefully that helps answer that question. And then you would see, you know, I want to download, you can see what this application looks like. It's like a 20-page application, although the back material is really just informational. You're not filling out 26 pages. It's just, there's a lot of information there. So does that help? This might be a little bit more in the weeds, but just sometimes it helps to see it visually than just sort of hear it.
Yes, thank you.
Thank you. Okay, so I'm just scrolling up to make sure that I am up to the right question. One moment. Okay, there was a question about the deadline to become a doula, but I feel like that was from our presentation yesterday. The question, the deadline still today at 5 p.m.
Oh, so the deadline is, that's only the deadline if you want to apply to be considered for that free training, which, did we put that in the chat, or did I forget to put that in the chat?
I think Rhiannon put that in the chat.
Okay,
Yeah,
thank you. The bit.ly.
Yes.
That application deadline is today. However, there are also other ways to get training, and there's no deadlines for that. Like if you want to get your training somewhere else, not through that program, there would be no deadline there. And Rhiannon, did we put in the approved trainings document just for people's awareness? I forget whether we did or not.
I don't think so, but we can.
Okay, let me, if you click on the approved trainings document that I think Rhiannon is going to put in the link, it's a 5-page document, and you can see there are additional trainings offered, additional training sites. There's 4 of them on the first page, and then there's 5 more doula training sites on the second page. But just to be clear, those may not be free. Some of them are at cost. The special thing about the one that the Doula Learning Collaborative and the one that we've shared today, the special thing about the one that the Doula Learning Collaborative and we have shared today, the bit.ly URL, is that training is funded by state dollars and is going to be of no cost to those who are interested in getting trained. So that's the unique thing there.
Awesome. So our next question is about midwives. So the question is, are there midwives that are available through New Jersey Family Care that work outside of hospitals or birthing centers that insurance can help cover?
Michelle, do you want to?
Sure. So there are midwives that would be covered by New Jersey Family Care or Medicaid fee-for-service. And if you're in a managed care, you could call the managed care directly to see if you can get a list of those providers. Some of our managed cares are covering birthing center births. Not all of them are. And so you'd have to, speak to your managed care plan directly to ask them about that. So it may be covered. I can't say that all of them are covering that now. And we actually are working another coming soon maternal initiative. We are expanding our midwife coverage. So there was some budget language that allows for all midwives that are licensed in the state of New Jersey to become providers of Medicaid. So we are working on expanding our midwife access to include not just certified nurse midwives, but also to include certified midwives and certified professional midwives. So we are working on expanding coverage, and we will be trying to work on birthing center availability as well.
And to the question I see in the chat about whether that includes certified professional midwives, I think Michelle just said yes. So it's certified nurse midwives, and certified professional midwives. All of them can begin to provide shortly. we're working on that. You'll hear shortly about the work that we've been doing around expanding midwifery access to Medicaid members in New Jersey.
Thank you. Were you going to say something, Shannon?
I'm trying to find these. I see these other questions I had. There was a question about how to apply for Medicaid online, and then also the county. And so I'm just trying to find that information. I'm sorry.
Oh, no, you're fine.
Wanting to get to all these questions because they're all very good.
Yeah, they are good questions. There's another question here about, I know you spoke about the NJ SPCP. And so there was a question about updates in the future about doula services. Is there a place or a website that you all can share?
Yeah, so we usually share any updates to our coverages through that NJMMIS website that Shinyi actually pulled up on the screen. So when we add or make any changes to our services, we place a newsletter there for our providers to see. I know, so once we update that coverage for the NJSPCP program, that's where we would notify those providers.
And did you all speak about the doula billing already? I know you gave a little overview, but I wasn't sure. There was a question about how doulas are billed for visits and if they're reimbursed per visit or in a lump sum.
Yeah, they're billed per visit, and that was partly because we had heard that in talking with our doulas that you know, the grant model had been a bundled rate, but because we heard don't be prescriptive, allow for shared decision making, allow for different models. So that's why we ended up going instead with the per visit model, because we didn't want to say, if you don't do this bundle, you don't get access to doula care. We wanted it to be expansive. So it is reimbursed per visit.
Got it. Okay, thank you. And sorry, I'm getting lost as the chat continues. Okay, so the next question is breastfeeding support a separate entity or included in doula training and services?
Both, both and. So the doula trainings that are accepted for the trainings that are accepted by New Jersey Family Care. So if you get a New Jersey Family Care Community Doula, they will have had some amount of breastfeeding support that's usually connected to sort of like core doula competencies. But you know, that does not replace lactation support provided by a counselor, by a peer counselor, peer support, or by lactation consultants. And breastfeeding support is another place that Medicaid has been working on. Michelle, do you want to talk about what has already been implemented and then what is coming?
Sure, I'll briefly talk about that. I'm not sure where we are on time, but so New Jersey Medicaid already covered breastfeeding equipment, and we have updated those coverages. So Now we have updated and expanded those coverages where a mom who would like to breastfeed can obtain a breast pump without the requirement of a prior authorization. They can access that pump. They could talk to their provider, or they can go directly to a medical distributor, or I'm sorry, I'm drawing a blank for the word, but they can go obtain that breast pump from a supplier without prescription, without a prior authorization. And they can access that anytime during their pregnancy. So early on, if they decide they want to breastfeed, they can obtain that breast pump. So we've also expanded that to include supplies. And if there are additional supplies, for instance, if flanges don't fit, if a new flange is needed. So we've expanded that for mom to receive all of those accessories without the requirement of a prescription or a prior authorization by their provider. Also included in that is bags for pumping as well.
And I think the goal there is just to, we've laid out more explicitly that all the different types of pumps as needed would be available to members. So a manual, single user, a double electric, or a hospital grade pump when necessary. The hospital grade pump is one of the pumps that you do need to show that there is a medical need for that. So there is that what Michelle called prior auth, which is just a way of saying that you need to show that you have medical need for that. And that was that expansion and clarification of our breastfeeding equipment coverage was put into place over a year ago. And then we are currently working on the people side of that. So we are working on providing more explicit coverage of IBCLC trained lactation consultants, and then also looking to go into broader lactation support outside of IBCLC, so or not limited to IBCLC. So we're still working on that. So probably you will start hearing about that as well from Medicaid in the coming in 2022.
Thank you. Looks like we have 2 more questions. The next question is about the postpartum expansion and what that looks like for clinical care and practice.
So I believe what this question is referring to is that last fall, there was an announcement that, New Jersey was the second state in the nation to expand postpartum coverage to 365 days. And so just to be clear, because maybe bigger framing is that in general, to be Medicaid eligible, you have to hit certain financial eligibility limits. So for example, specifically, if you go to that NewJerseyFamilyCare.org site that I linked to, it would say, so right now, for example, adults, it would be income up to 138% of the federal poverty FPL. And but we know in particular that pregnant people, we want them to ensure that they get access. So their financial limit is higher. So we're more expansive. We allow people who maybe normally wouldn't be financially eligible, but if they're pregnant, up to 205% income FPL, then they would get this pregnancy related Medicaid coverage. And before the COVID hit, New Jersey used to be at 2 months postpartum. So you would get coverage from whenever you became pregnant all the way to 2 months postpartum. Even before COVID, New Jersey was working to expand out from 2 months postpartum because we know so much important clinical care and access is important to medical care during that full postpartum period, the full 1 year, you know, the 4th trimester and beyond. And as was announced last fall, it's now up to the full 365 days. But just to be triple clear to everyone on this call, currently, due to the public health emergency, anyone who gets on Medicaid is not coming off Medicaid. That's regardless of pregnancy. So any member who's gotten onto Medicaid, part of the rules during this public health emergency is that people are not losing coverage during a pandemic. We obviously want to maintain coverage. And so what that expansion announcement is saying is that whenever the federal public health emergency ends, which might happen sometime this year, that if you were on Medicaid due to pregnancy, we already have it in place that you'll get the full 365 days. So what that means is, so for example, is if the public health emergency ends and you're 2 days postpartum, you would get the remaining 363 days. If the public health emergency ends and you're 6 months postpartum, you would get an additional 6 months once the PHE ends. And that postpartum coverage is full Medicaid. So it's not just postpartum clinical care. You can, if you have, want to be screened and get some mental health training or treatment because you're, having some postpartum blues or postpartum depression, you can get that coverage. You can get coverage for any other chronic issues that maybe had come up, like maybe you still have lingering blood pressure issues, or maybe lingering diabetes related to gestational, whatever it is, you can also get that kind of coverage. That expansion is regular full Medicaid.
Thank you so much. And our last question was from Jill, and it was about CPM. And so she might be able to clarify her question a bit better, but she said, will this be CPM as well, or for CPM?
So yeah, I think Jill is referring to the expanded coverage of our midwifery care. So right now, New Jersey currently covers certified nurse midwives. And as we expand, we will be including certified midwives as well as CPMs, or certified professional midwives.
Thank you. So I think that was our last question. And so I would just like to thank you all for joining us. We really appreciate your expertise and taking the time to answer these questions. This is super exciting for the state of New Jersey. So we were really happy to hear from you, and looking forward to see, what's going to happen in the future. So we are going to take a 15-minute break. So again, thank you all. If those of you who are on the call would like to stay on, but maybe go get a drink of water, take a bathroom break, we'll be here. But we are going to take a 15-minute break. And if there's anything else that anyone wants to say before you all leave the call, feel free.
I think if I can just, first of all, thank you guys so much. I don't know how much my kids came over the phone, over the Zoom line, but thank you so much. I hope that, just so you know, I had all 3 of my kids here, and, at least from my own personal perspective, I'm very committed to improving maternal health outcomes. I'm a mom. All the stories I've been hearing on this call, I feel resonate with me to different degrees. So I just want to thank everyone who's committed to this work, and say, I definitely share in your little, in the passion to really work on this from a Medicaid perspective. And Rhiannon and Michelle, please, I want to give you guys last words.
Just wanted to say that is correct. Agreed. We are happy to be part of this conversation. We are working at Medicaid to, try to get these benefits out, and we are passionate about what we're doing and trying to get it right. So we're always happy to talk about it. So thank you again for having us.
And like I said in the chat, thank you again, everyone, for just having us and for also being here and being present in the conversation. My first job out of college was for Sister Song, which is a reproductive justice agency in Atlanta, Georgia, and one of the founding members of the Black Mamas Matter Alliance, which spearheads this Black Maternal Health Week. And so all of this is near and dear to my heart. I gave birth on Medicaid in Georgia. And we all know the statistics with Georgia and giving birth there. I also was fortunate enough to have access to a doula. And so myself and my baby definitely wouldn't be here. And she's not a baby, she's 11. We wouldn't be here if it wasn't for that support. So we're all in this. It's all personal to us. And I'm just excited to continue to be a part of conversations like this where solutions are actually being posed to addressing this problem.
Awesome. So we'd like to thank all of our speakers one more time. Thank you so much for joining us. And to those participants that are here with us, we're going to resume at 2:10. So again, if you would just like to take a break, take a moment for yourself, we'll be back at 2:10. So thanks again. Okay, so we're recording again, and let me just make sure I give all the speakers the ability to share their screens. Okay, so it looks like everyone should be able to share their screens now. I'm going to do 2 introductions, which I'm super excited to introduce these 2 beautiful ladies. They're going to be talking about the New Jersey birth policy to know. So we'll be talking more about policy, but especially policies that you should be aware of. So our first speaker is Jill Wadnick. She is a Lamaze childbirth educator and policy expert working at Montclair State University on improving maternity care. She has advocated for respectful, equitable maternity care for close to 20 years through maternal health advocacy, policy, and direct services. She's worked at the state level with the Office of First Lady's Nurture New Jersey project. She's worked with the New Jersey Perinatal Quality Collaborative, the New Jersey Hospital Association, and the list absolutely goes on. And so Jill is a great proponent for maternal and child health in New Jersey. She really focuses on environmental justice and ecological sustainability for labor and life. So we're super excited and happy to have her here with us to speak. And then last but not least, Ellen Mon. She is an IBCLC, a retired attorney and mom of 3 breastfed children, or rather kids that are grown up now. And she's been helping families achieve their lactation goals for over 26 years, first in peer-to-peer breastfeeding support, and then as an international board certified lactation consultant, which is, I refer to it as IBCLC, but that's what that acronym means. And now she's a policy consultant. Ellen's lactation support journey was birthed from the struggles and empowerment she experienced while breastfeeding her firstborn son and her 2 daughters. And so we are super excited to have Ellen here as well. And so we can get started whenever you all are ready. And are you able to share your screen, Jill?
Yes. Yeah, I just did.
Cool. Thank you.
Great. Thank you so much. Thank you so much to Dr. Davis. Thank you so much to the Perinatal Health Equity Initiative. All week, these conversations have been fantastic. And I really appreciate that they're on Facebook Live. I can go back to them, and I know just the conversation that was happening right before this one was so filled of such essential and important information. So thank you for the inclusion, for the visibility of just centering New Jersey as we go deep into the critical urgency of Black maternal health and everyone's urgency of making this a priority centered in love. So I'm going to start just really by going into a federal overview with a little bit of New Jersey and then passing it on to Ellen. What we can say about maternity care in the United States from lived experience, from data, from reports, and from resources can be summarized in a variety of ways. But what I like to hear, unfortunately, with the urgency, is that maternity care can be defined as too much too soon or too little too late. With that place of humility, with that place of urgency, we understand, what does this mean for New Jersey? Well, I've done a couple of screenshots, and so the cropping may be off. But up on my left-hand side, it's called the New Jersey Maternal Data Center. I'm going to put the link in the chat in a few moments. And what you can find, I just happened to find a birthing facility in Essex County where I work. And what we see are the vaginal birth after cesarean is 1%. The cesarean birth rate is 38.2%. The episiotomy is 6.2%. And we can continue with this building specific data because of the New Jersey Maternal Data Center. But what I really want you to know is that that is available because there was legislation for maternal health transparency, and it's recent. This is a bill, again, I just kind of did a screenshot that shows you there was a bill that was introduced in 2018. It's not too long ago. Assemblywoman Valerie Huddle, State Senator Weinberg, State Senator Nia Gill, Senator Ruiz, some of these are very familiar policymakers in New Jersey and legislators, had a bill that was specifically about creating a New Jersey report card for maternity care. And so now we have that. And sometimes, though, the challenge is what is the role of legislation for quality care? Sometimes it starts with visibility. Because when we think about quality care, under the understanding of too much too soon, too little too late, the United States is using, in an overusing capacity, induction, analgesia, cesarean births, episiotomies at a rate that's not safe nor sustainable. However, we're underutilizing things like labor support, non-supine positions for birth, skin-to-skin contact, interventions for breastfeeding, initiation, and duration, as well as interventions for postpartum depression. And so this is the tension that we are holding. And what is the role of legislation with this? Well, 3 weeks ago, there was yet another piece of proposed legislation in New Jersey. So if you happen to be listening to this from Camden or Gloucester County, you may already know this because this is from New Jersey State Senator Nilsa Cruz-Perez. And she has a piece of proposed New Jersey legislation, came out a few weeks ago, that is looking to expand upon the maternity care report card. This time it would expand looking at indicators of quality. And this is a really long slide, but I literally just copied her piece of proposed legislation. It would really disseminate that data about cesarean births, exclusive breastfeeding, vaginal birth after cesarean, some of the things we already have, but it goes a little deeper in terms of patient rights, shared decision-making, even down to paid leave, the Medicaid program. So this is a very specific New Jersey piece of legislation to go beyond just the maternity care report card into services and policies and make them more visible. So why policy? You know, with all of what I just said, too much too soon, too little too late, the urgency of transforming maternity care at the state, national, and personal level, Well, this is a slide from a colleague of mine who gave me permission to share from the USBC, who really looked at this question of why policy. And what Cheryl Lebdovich wrote is why policy change? Because, as we know, there are significant persistent disparities in outcome and access. We have plummeting breastfeeding rates the weeks after birth. This is so true for New Jersey. Something's going wrong. So policy and legislation can be the lever to help drive that. And so here's an example. The March of Dimes is using a hashtag called blanket change and a picture of a baby blanket. Under their values of equity, access, and prevention, they're telling the story that policies, in fact, can make a difference. And their policy priorities include expanding Medicaid, paid leave, expanding group prenatal care, increasing access to telehealth services, and expanding access to the midwifery model of care and doula care. So why policy change? Because policies can make a difference. At the federal level, we have proposed policies that in particular are getting strong amplification this week in Black maternal health, from the Office of the White House to local and federal legislators. The Momnibus was reintroduced, and this time has a series of 12 independent yet interdependent pieces of legislation. And although we're talking about New Jersey, I do want to frame New Jersey as part of these national conversations that are happening. And so the Black maternal health Momnibus that was reintroduced has very specific language for each of the bills under the umbrella. And that can get a little bit complicated, especially based on funding sources. So I really appreciate that the Century Foundation has what's called a tracker to track the progress of all of the interrelated Momnibus bills at the federal level. You can find them on Twitter. I'm going to put this in the chat in a few moments. And you can really look at the individual bill and see where it is and what the status. So let me give you an example. One of the pieces of the Black maternal health Momnibus, initially introduced by Representative Lauren Underwood and Senator Ed Markey, is called Protecting Moms and Babies Against Climate Change. And you can see the infographic that the Black Maternal Health Caucus did to really try and explain that this is one of the standalone bills under the Momnibus. So if you want to track that and see, well, how's it going? You can use the tool from the Century Foundation, and we can understand that it's actually the investment for that is included in the Build Back Better. And this tool will really help because they're going to give a summary of it at the federal level. They're going to let you know the status. Is it considered bipartisan or not? And a fact sheet. And the fact sheet, I think, can be really helpful because, again, you can see, does it have both a House and a Senate introduction? And so this is just a screenshot of the fact sheet. And so these are the ways that we know that policy and legislation can absolutely inform direct lived experience about high quality maternity care. And I chose this example. All of the bills in the Momnibus are essential and interdependent, and yet they do also stand alone. This one I wanted to highlight because New Jersey just a few months ago had a very significant impact of flooding and climate change. And we saw that, again, this specific bill in the Momnibus is specifically about climate change and resources that would be mobilizing for pregnancy and breastfeeding. And so there is a uniqueness of each of the bills, and yet they all work together. And this is something that we know every state needs, and New Jersey is still feeling the impact from in some areas. I also want to say that just today, Congresswoman Gwen Moore, who is from Wisconsin, at the federal level is reintroducing a bill that's not part of the Momnibus, but really still adds to the conversation and the dialogue. So what she is reintroducing is called the Mama's First Act. So you can follow her on Twitter, you can watch this introduction, and it's very significant, especially based on the presenters right before me from my colleagues at the New Jersey Office of Medicaid. What this would do at the federal level is amend the Social Security Act to provide coverage under Medicaid for doulas and midwives. One of the things that makes this significant is the inclusion for the full landscape of midwives, including tribal recognized midwives, certified professional midwives, and certified midwives. And so follow this, even though it's not part of the original Momnibus, it's adding impact and visibility to legislation that's happening right now, and that we were hearing a little bit of mirrors of policy happening in New Jersey. Another quick piece of legislation I just want to amplify is called the Babies Act, which is about birth centers. And right now in New Jersey, there's only one co-sponsor in New Jersey for this federal bill that would use Medicaid beneficiaries to get access consistently to birth centers. Finally, as I prepare to share to Ellen, I want to say that workplace breastfeeding policies are also part of what's happening at the federal and state conversation. The Pumping Act got through the House of Representatives in October and now is looking to go through the federal Senate. You may want more information from advocacy toolkits from Every Mother Counts, coming back in person to March for Moms in June, or looking at resources from the National Partnership for Women and Families that really give all of this synthesis of policy, legislation, and tools for education. I say with humility. On Twitter, as I was preparing this presentation, I follow a lot of people on Twitter, and there's all this market research happening. And I think with humility, it's really important to say, read directly what BirthX app wrote. They were doing market research and they asked American childbearing people what the concerns about giving birth were. White people giving birth soon were concerned about pooping while pushing. Black people giving birth soon were concerned about dying, being neglected by healthcare staff. So if we don't address the urgency of now with humility, with mobilizing resources, we will continue to have inequitable, unacceptable outcomes for families and communities. And so I provide words from the continuity of care breastfeeding support as I transition to Ellen that says, provider and institutional racism, implicit bias, and discrimination also adversely affect the breastfeeding journey for many Black families. In addition, Black families are more likely to deliver at birthing facilities that do not implement evidence-based maternity care practices and support breastfeeding, which make less likely initiation. Access to timely lactation support and supportive environments is an issue of equity and social justice. Thank you for this beginning conversation on the federal landscape and New Jersey policy. I'm going to stop sharing and pause and welcome Ellen's voice. Thank you so much.
Thank you so much, Jill. And I echo everything that my cherished colleague Jill has to say. And I'm also here to say I'm really honored and grateful to be sharing this time with you, and honored and grateful to be partnering with the Perinatal Health Equity Initiative today during Black Maternal Health Week, but every day. And we are so grateful for the work that you do. I'm here to talk today about New Jersey policy pretty exclusively, and especially lactation-related laws that are in effect. And as Jill said so very well, but I would like to expound on is lactation laws and policies are really essential to address those systemic and environmental barriers that exist to breastfeeding that are mentioned in the NACHO report, and also just to normalize human milk feeding. Starting out in New Jersey, we're lucky to have many progressive laws, and I wouldn't consider public breastfeeding law to be so progressive, but we have had one in effect since 1997. And our New Jersey law, though it's still misunderstood, says that notwithstanding any provision of the law to the contrary, a mother shall be entitled to breastfeed her baby in any location of a place of public accommodation, resort, or amusement, wherein the mother is otherwise permitted. And that's a very broad law, often misunderstood. Many think that that doesn't apply to private property, but places of public accommodation include most places. Places where the public is invited into to be stores, restaurants, physician offices, public offices, taverns, schools, so many places. In fact, probably the only places that are not covered by the law are private membership clubs and possibly churches. That law is enforced by making a complaint in writing to the local Board of Public Health. And when that complaint is made, a health official will investigate and notify the complaint, and monetary penalties are available in certain circumstances if the offenses are repeated. And here I have just copies of some breastfeeding rights cards that are available for download on the New Jersey Breastfeeding Coalition website. Great a resource for those of us who support breastfeeding lactating families, and also to give out to families themselves. In the workplace realm, there are two existing workplace lactation support laws that are enforced and affect us in New Jersey. Jill mentioned the federal lactation support in the workplace. It's called the U.S. Break Time for Nursing Mothers Law. It is part of the Affordable Care Act. And then in New Jersey, we have our own particular law. Our workplace lactation protections are found in the New Jersey Law Against Discrimination. I just want to contrast the two for a second. The federal break time for nursing mothers law, it does cover all US states and requires employers to provide reasonable break time to employees to express milk, need not be paid break time, a place other than a bathroom that's shielded from view and free from intrusion from coworkers and the public. And those protections can last for up to 1 year after the birth. Smaller employees having less than 50 employees may sometimes be exempted if they're able to prove undue hardship. However, there are gaps in the federal law, only covers hourly employees. Of course, pumping breaks are unpaid. The duration is only for 12 months. And there certainly is a lack of awareness, and there are certainly loopholes that are exploited. But those loopholes are, there's an initiative to plug up those loopholes, and that is the Pump Act that Jill mentioned, which is wending its way through Congress. However, I want to emphasize, though the break time for nursing mothers law was in place for longer, that we have a more recently enacted New Jersey law that's stronger than the federal law. And it's the one that I want you all to know about and to claim rights under and to raise awareness about. And again, that law is found in the New Jersey Law Against Discrimination. That law adds breastfeeding to the list of protected statuses, the usual protected statuses in anti-discrimination law, including race and creed and color, religion, sexual orientation, and marital status. New Jersey's law is stronger than the federal break time for nursing mothers law. In New Jersey, employers are required to provide reasonable break time to express milk, a private place to pump other than a toilet stall that is notably in close proximity to the employee's work area. It doesn't help so much to have a lactation space if it's not close by. There's no time limit on the New Jersey accommodations, meaning that if an employee wants to pump for more than 1 year at the workplace, it is possible. And New Jersey's law applies to all employees, whether they're hourly employees or salaried employees. So that's stronger and more inclusive than the federal break time law. If you feel that your rights have been violated under that law, your recourse is to file a complaint within 6 months or 180 days with the New Jersey Division on Civil Rights. And you can do that online or by telephone. Or you have the choice to go directly to Superior Court, where you can actually get monetary damages if you're interested in that. And that would be, you have 2 years within the 2 years of the violation to file that claim. And always in any of these situations, it's wisest to consult with an attorney in the New Jersey Division of Civil Rights for more information. There are resources out there to help you understand better those workplace protections. The New Jersey Division on Civil Rights has a great handout, 5 accommodations for pregnancy and breastfeeding at work. And the New Jersey Breastfeeding Coalition has fact sheets, both for employees and employers, explaining workplace breastfeeding rights in New Jersey. New Jersey Breastfeeding Coalition also has a great infographic, which is available both in English and Spanish, which is lower literacy. On our website, we also post other information, including a guide developed by our friends in Montclair State University, a guide for families, Breastfeeding Works, which helps families that are returning to work to navigate that change and navigate childcare and continue to be able to breastfeed and provide human milk. And New Jersey Breastfeeding Coalition has also developed a guidebook with the support of the Reinvestment Fund of Philadelphia for childcare staff called Breastfeeding Babies Are Welcome Here, Creating Breastfeeding Friendly Childcare in New Jersey. You can download those all from the New Jersey Breastfeeding Coalition website. Just moving on, there are other lactation related laws. And I know that the previous presentation touched on this, that in New Jersey, insurance and Medicaid coverage are required for lactation support and equipment. So our laws requires commercial insurance carriers and the state Medicaid program to cover, without any cost sharing, comprehensive lactation support, counseling, and consultation for the duration of breastfeeding and in conjunction with each birth. As said in the last presentation, that coverage for Medicaid is in the works right now. We're hopeful that that will be announced and that guidance will be announced this year. But that Medicaid has already put out guidance and is reimbursing for the cost for renting or purchasing electric or manual breastfeeding equipment. So the pump part is in effect. The coverage, Medicaid is not fully in effect. The coverage for the insurance coverage, while it is mostly in effect, I just want to make clear that not all insurance companies or not all employees are covered by their insurance. If your company, your employer, carries a self-insurance program, you're not covered. But if they purchased commercial insurance plan from a provider, then you would be covered under this law. New Jersey law also requires insurance and Medicaid coverage for pasteurized human donor milk under certain circumstances. Under that law, milk must be obtained from a human milk bank that meets the quality standard guidelines of the New Jersey Department of Health. We're still awaiting those guidelines, so this law is not fully implemented yet. However, we want you to be mindful of it and to be looking for it and to be asking for it and asserting that we want this to happen very soon. In this case, infants under 6 months will be covered, and it must be ordered by a licensed medical practitioner when certain conditions are met. New Jersey also has hospital licensure standards on breastfeeding support, and they've been in effect since 2014. Those regulations require that all New Jersey hospitals and birthing centers develop and implement policies that support breastfeeding families. And those regulations are pretty extensive. They cover a lot of bases. If you would like more information on them, unfortunately, there's not the time to get into them today. That's almost like another presentation. However, those regulations are available on the New Jersey Breastfeeding Coalition website. And if you have questions, I can address some of those. Fortunately, New Jersey is one of the limited number of states in the United States that also has available New Jersey Family Leave Insurance. And that provides for paid leave for both parents to bond with a new child in the first year after birth, and can also be used to care for a seriously ill loved one. To be eligible for New Jersey Family Leave, you must have worked at least 20 weeks and earned at least $240 in those 20 weeks, or at least $12,000 in what they call the base year. And that family leave insurance is now available in 2022 for 12 weeks and provides workers with 85% of average weekly wage up to $993. New Jersey temporary disability insurance for pregnancy is also available, and that provides wage replacement when you are unable to work due to a pregnancy or childbirth-related physical disability. The standard duration is 4 weeks before the expected delivery date and 6 weeks for a vaginal birth, 8 weeks for cesarean birth after actual delivery, and with the potential for a longer period if there are birth complications. If you need more resources, I would refer you to our friends at Montclair State University. We've cited the NACHO report, the National Association of County and City Health Officials. You can find out more at their website. I've given the website for the New Jersey Division on Civil Rights, and the New Jersey Department of Labor has lots of information about temporary disability and also paid family leave. New Jersey Citizen Action and the New Jersey Time to Care Coalition are also amazing resources for temporary disability leave and the paid family leave. And if you want to learn more about breastfeeding and lactation-related laws, I certainly would direct you back to the New Jersey Breastfeeding Coalition website, and also possible to send questions to our Gmail account, New Jersey Breastfeeding Coalition at gmail.com. And I should say the Breastfeeding Coalition. And I thank you all, and happy to be here today. Really excited to be here and to lend more support to all the work that you're doing at the Perinatal Health Equity Initiative. Thank you.
Thank you so much, Ellen. Thank you so much, Jill. Such great presentations. We really appreciate your time today. Just want to ask our audience if they had any questions, please feel free to put them in the chat so that we can get those answered for you. In the meantime, I do have one question that I'd like to pose, and that's how can people who are not directly involved in this work advocate and or participate in the conversation around New Jersey breastfeeding policies?
Well, I can jump in there. Certainly in the New Jersey Breastfeeding Coalition, we're actively involved in them. And we have what we call our advocacy committee, which I work on. So certainly reaching out to the New Jersey Breastfeeding Coalition is an option. At the federal level, the United States Breastfeeding Committee is an amazing resource, and they work tirelessly with a good-sized staff to stay on top of federal legislation and to advocate for it. So would certainly recommend those two resources.
Thank you, Ellen. I don't see any questions in the chat, but that was very helpful, and thank you for sharing those resources. Do you all have any last words or anything else you'd like to share? Okay. All right, so I'm going to go ahead and close out. On behalf of the Perinatal Health Equity Initiative, I would like to thank each panelist and participant that joined today's call. Policy plays an instrumental role in maternal and child health. And so today's presentations were enlightening, and personally to me, they were really impressive. So we're really grateful for all of your expertise. We hope that all the participants enjoyed today's presentation. Tomorrow's discussion will be surrounding birth. So our presentation tomorrow is called My Black Beautiful Birth. And so we will have some celebrity panelists we're really excited about that will be sharing their stories about their lived experiences as birthing moms, as breastfeeding moms. So if you can, please join us and register. And of course, if you have any questions, feel free to reach out, but definitely please spread the word. And if you would like to donate to the Perinatal Health Equity Initiative, we do have a link on our website so we can continue to do this work. So thank you so much for joining us. I don't know if Nastasia, if you have anything before we go, but otherwise I think we're gonna wrap up. So thanks again.